It's 2:00 p.m. on a Tuesday. You open the chart for your next patient and you see the chief complaint. Abdominal bloating, distension, erratic bowel habits, duration. 6 months, maybe longer. You walk in and they are frustrated. And, well, honestly, you are probably a little frustrated too. You suspect, or maybe I've already confirmed it with a breath test, small intestinal bacterial overgrowth SIBO.
It is the classic outpatient clinical struggle. You want to fix it, but SIBO has this, notorious reputation for being recalcitrant. It just loves to come back.
Exactly. And you know the playbook, right?
Yeah.
You reach for rifaximin. It's the gold standard for non-constipated or hydrogen-dominant SIBO. But then your hand just sort of hovers over the duration field in the EMR.
Yeah.
Do you write that prescription for the standard 7 days, or do you push it to 14? Do you go with the standard, or do you go for that knockout punch?
That hesitation is exactly what we need to dissect today. We are looking at the optimization of rifaximin duration for uncomplicated outpatient SIBO. It sounds like a minor detail, 1 week versus 2, but it touches on everything. Stewardship, pharmacology, cost, patient outcomes.
Because the instinct in modern medicine, especially when you're dealing with a stubborn infection, is usually more is better.
Right.
We want to sterilize the field. But today's discussion suggests that that instinct might actually be leading us astray. We're going to build a decision framework to answer the question. Does that extra week of antibiotics actually buy you anything other than a higher bill?
Spoiler alert for the clinicians listening.
Yeah.
Often it does not.
Yeah.
But to understand why, we really have to look at the mechanism.
Okay, let's start there. Set the stage for us pharmacologically. In GI and primary care, rifaximin is the heavy hitter. Why is it the default over, say, cheaper systemic antibiotics like Cipro or metronidazole?
It all comes down to its pharmacokinetic profile. Rifaximin is a structural analog of rifamycin, but it's virtually not absorbable.
Not absorbable.
We're talking less than 0.4% systemic absorption. It just stays in the gut lumen.
So it achieves high local concentrations right where the bacteria are without the systemic tox.
Precisely. It achieves incredibly high concentrations in the small intestine. Fecal concentrations can exceed 8,000 micrograms per gram. But since it isn't absorbed, you avoid those systemic side effects, and you avoid the profound disruption of the extraintestinal microbiome.
Which brings us to the standard of care. If you poll a room of GIs, the reflex prescription is usually 550 milligrams 3 times a day for 7 days. Why is 7 the magic number?
It's a calculated balance. When we prescribe a 7-day course, we're acknowledging 2 things. First, efficacy. We know it works from the pivotal trials.
Sure.
But second, and I'd argue more importantly for outpatient management, is stewardship. Even though rifaximin is largely non-systemic, we treat it with respect. We're trying to minimize total antibiotic exposure.
Because every single day you keep a patient on an antimicrobial, you are theoretically rolling the dice on disrupting the colonic microbiome, right?
Correct. Even with rifaximin's safety profile, you are exerting selective pressure on the colonic flora. There is a theoretical risk of selecting for resistance, especially regarding, Enterobacteriaceae or Enterococcus species in the colon.
So the 7-day course is the prudent baseline.
It is. It minimizes cost, which is not a small factor with this drug, and it minimizes that theoretical resistance risk.
So for an uncomplicated patient, the logic is that 7 days is usually enough to knock down the bacterial load to a level where symptoms resolve.
Yes. We aren't trying to achieve sterility. The small bowel isn't sterile anyway. We're just trying to reduce the pathological overgrowth, the dysbiosis, back down to a physiological range.
Okay, but I'm going to play the devil's advocate here. I'm the clinician in the exam room. My patient is miserable. They've been bloated for a year. And my gut instinct, pun intended, is to say, I'm not taking any chances. Let's do 14 days. Let's make sure it's dead. Why is that wrong?
That is the more is better fallacy. It's an intuitive thought, but it's just not supported by the data for uncomplicated cases.
But logically, wouldn't 14 days kill more bacteria than 7? I mean, if I scrub a floor for 10 minutes, it's cleaner than if I scrub it for 5.
In a petri dish, maybe. But we aren't treating a static surface. We're treating a complex, dynamic ecosystem. Here's the reality check from the clinical data. When you compare 7-day courses to 14-day courses in uncomplicated SIBO, there is no clear evidence that the 14-day course is superior. Not for the metrics that actually matter.
Which are what?
Symptom recurrence and relapse prevention. You might see a marginal difference in immediate breath test normalization in some smaller studies, but does that translate to the patient staying symptom-free for 6 months?
And the data says no.
The data says no. The curves for relapse are virtually identical.
That feels very counterintuitive. You'd think double the exposure equals double the killing power.
It feels that way because we're trained to think of infection as binary. You have it or you don't. But SIBO is a state of imbalance. If you knock the population down significantly with 7 days, going for another 7 often hits a point of diminishing returns.
You're hitting the flat part of the curve.
Exactly, you've done the heavy lifting. That second week isn't adding significant therapeutic gain, it's just adding cost and exposure.
Okay, let's talk about that cost. Rifaximin is not cheap. In the U.S., a 2-week course can be astronomically expensive if coverage is spotty.
It's a major barrier to care. If you double the duration, you double the cost. Now, if the data showed a massive drop in relapse rates, say 50% less recurrence with 14 days, we could justify that financial toxicity.
Sure, it would be a clear win.
But since the efficacy for relapse prevention is comparable, prescribing 14 days as a default is basically asking the patient to pay double for the same clinical outcome.
That's a hard sell. Here, pay significantly more and you'll have the exact same chance of being bloated again in a month.
Yeah, I don't think any of us would sign up for that plan.
What about safety? Is 14 days dangerous?
Dangerous is too strong a word. The safety profile of rifaximin is excellent. We don't see a massive spike in adverse events like C. diff when we extend to 14 days. It is generally very well tolerated.
So it's not that it hurts them.
No, it's just that it doesn't help them enough to justify it. We're operating in a gray area. It's a neutral intervention with a high cost. And in evidence-based medicine, we shouldn't be relying on neutral interventions.
Okay, so if we strip away the more is better bias, we need a framework. What is the rule we should be following?
The decision framework is start low, monitor closely. The core rule for every clinician listening should be this. For uncomplicated outpatient SIBO, you initiate with 7 days.
That's the starting line.
That is the default. You write the script for 1 week, and you explain to the patient, we're going to do a targeted course. This is usually enough to reset the environment.
And because this is where the outpatient part gets tricky. Patients get lost to follow up.
And then you wait and see. This is the part that takes more clinical effort than just writing a bigger script. You have to track them. It requires a treat and track approach, not treat and release.
So you don't blast them with 14 days just in case. You treat for 7 and you assess. Did the bloating resolve? Are the bowel movements regular?
Exactly. If the answer is yes, you stop. You're done, you save them money, and spare their microbiome unnecessary exposure.
But this framework falls apart if we don't know when to deviate. There have to be exceptions. I'm picturing a patient who takes the 7 days, feels better for 2 days, and then calls the office saying, it's back.
And that is your first pivot point, immediate recurrence. If symptoms come back within days or a couple of weeks of stopping the drug, that suggests the 7 days was insufficient.
So in that case, the 14-day course is justified.
Absolutely. If they fail the 7-day trial or have that immediate recurrence, you have now clinically justified the extension. You're not guessing anymore. You have N of 1 data on that specific patient showing 7 days was inadequate.
What about persistence? They finish the 7 days and say, Doc, I feel exactly the same.
That's a fork in the road. It could mean the bacteria are resistant or, well, it could mean you have the wrong diagnosis. Maybe it's SIFO or something else. But assuming you're confident it is SIBO, persistence is an indication to extend. You might go to 14 days or add a second agent like neomycin, but you definitely don't just stop.
Let's talk about risk factors. Are there patients where you look at their history and think, 7 days is not going to touch this?
The biggest red flag, the one that should immediately make you consider a more aggressive or prolonged approach, is the use of proton pump inhibitors.
Ah, the double-edged sword of gastroenterology. PPIs are everywhere.
They are. And mechanistically, they are the enemy of SIBO remission. Patients on long-term PPI therapy have hypochlorhydria. They've lost their primary defense mechanism against bacteria entering the small bowel.
They've lost the gatekeeper.
Correct. So these patients are constantly re-inoculating their small intestine. They have a demonstrably higher risk of recurrence. If I have a patient with Barrett's esophagus who must be on a high-dose PPI and they develop SIBO, I'm much more likely to consider a 14-day course from the start or be very quick to retreat.
Because their recurrence rate is driven by a mechanism we can't easily turn off. That makes sense.
Yeah.
What about other refractory cases?
Generally, patients with structural abnormalities, small bowel diverticula, prior surgeries, blind loops. These are complicated cases. The 7-day rule is for uncomplicated anatomy. If you have stasis due to anatomy, A short course often isn't enough.
I want to be very clear about exclusions. We keep saying uncomplicated outpatient. Who does this framework not apply to?
Right, we have to be very careful not to extrapolate this 7-day heuristic to complex inpatients. If you have a patient with scleroderma, severe diabetic gastroparesis, or pseudo-obstruction, their motility is so compromised that a 7-day course is like throwing a cup of water on a forest fire.
They need much more aggressive management.
They often need rotational antibiotics, prokinetics, the whole 9 yards. Do not use the start low rule for severe dysmotility cases. And of course, this framework excludes pediatric patients in pregnancy. The data we're basing this on just doesn't include those groups.
I want to bring up the elephant in the room, IBS. The overlap between IDS and SIBO is massive. Does an IBS diagnosis change the math on duration?
It's a bit of a red herring. It complicates the symptom picture for sure. Is the bloating SIBO, or is it visceral hypersensitivity from the IBS? But for the duration of rifaximin, the presence of IBS does not clearly alter the decision.
Really? I would have thought IBS patients are tougher cases that would need longer treatment.
They are tougher to manage overall, but for the specific goal of clearing the bacterial overgrowth, the 7-day start is still valid. In fact, because IBS patients often have chronic waxing and waning symptoms, you want to be even more careful not to overprescribe antibiotics every time they have a bad week.
That's a really good point. If you train the IBS patient that 14 days of pills equals relief, you're setting up a cycle of dependency.
And you risk attributing all their IBS symptoms to SIBO. You clear the SIBO, but they still have visceral hypersensitivity. More antibiotics won't fix that.
Which speaks to diagnostic certainty. How much does it matter that we know it's SIBO?
It matters immensely. Are we treating a positive breath test, or are we just treating bloating? If you have a confirmed diagnosis, a high hydrogen peak, your likelihood of benefit is high. If you're treating empirically,
You're shooting in the dark.
you're shooting in the dark, so you use a small bullet. If you aren't sure the target is there, don't use a cannon. If you treat empirically, you must stick to the 7-day course.
Okay, let's pivot to the don'ts. We've built the framework. Start with 7, extend for specific reasons. What are the myths that trip clinicians up?
Well, we've touched on the more is better myth, but the other big one is the monotherapy fallacy.
Thinking the antibiotic is the entire cure.
Right. We treat the bacteria, but we ignore the environment. SIBO is almost always secondary to something else, motility, diet, anatomy. If you give rifaximin for 14 days but don't address the diet, don't use a prokinetic.
It's just coming back.
It is coming back. And interestingly, if you use adjunctive therapies effectively, like a low-fermentation diet, you can often get away with a shorter antibiotic course. The antibiotic resets the baseline. The diet and prokinetics maintain the remission.
So rifaximin facilitates the lifestyle change. It doesn't replace it.
Precisely. Another trap is overinterpreting the breath test. Some clinicians see a massive spike hydrogen goes to 100 ppm and they think, oh, huge number, needs huge treatment, 14 days.
And the height of the peak doesn't correlate with the duration needed?
Not linearly, no. A higher peak means more gas, but doesn't mean the bacteria are harder to kill. You can have a massive bloom of very sensitive organisms that wipe out in 3 days. Treat the patient, not just the graph.
And finally, outcome measures. You mentioned this earlier. Don't just look at if they feel better on day 10.
This is so crucial. Almost everyone feels better on antibiotics because they have anti-inflammatory properties. Feeling better on the drug is not the metric. The metric is, do they stay better off the drug?
That's a distinction a lot of us miss. We take the I feel better as a win without realizing it might be temporary.
Which is why that wait and see after 7 days is so valuable. It separates the true responders from the placebo or anti-inflammatory responders.
Let's synthesize this. We have a listener, maybe a primary care doc or a busy GI driving to work right now. They want the golden rule for rifaximin duration.
Here it is. For uncomplicated outpatient SIBO, initiate rifaximin with a 7-day course. Extend the duration only if symptoms persist after treatment, recur immediately, or if significant risk factors like chronic PPI use or structural issues are present.
Simple, actionable. It challenges that impulse to overtreat.
It forces you to be vigilant. It forces customization. A blanket 2 weeks for everyone policy is, frankly, lazy medicine. It ignores the nuance of the patient in front of you.
And in a condition as frustrating and recurrent as SIBO, that vigilance, that willingness to track the patient is probably the most effective tool we have.
I agree. It's about doing the least amount of harm for the maximum benefit. Sometimes less is more with the drug, provided more attention is paid to the patient.
I think that's a perfect place to wrap things up. It brings us back to the art of medicine, optimizing the tools we have rather than just using more of them.
Apply the evidence to the patient, not the other way around.
Something to consider before your next clinic session.
Okay.
Till next time.